So hello everyone and welcome to the second case of this Osce series. So here we have a 55-year-old male who came with complaints of nystagmus, facial myoclonus and upper extremity tremors since the past 3 months now. And there is history of prior posterior fossa hemorrhage that was present. So what are the findings in this particular case? What is the pathognomic clinical feature that we see in this case and what is the pathophysiology behind this particular condition? So we have been provided with a GRE axial section of the brain, and these are the flare images, axial section. So here we can appreciate that there is some blooming in the dorsal aspect of the pons that is seen. Here in the medulla and the anterior aspect there is some signal change, which is very well appreciated here. So what do you think the diagnosis is in this case? Which nucleus lies at this level of medulla? What exactly is the diagnosis? So the diagnosis here is hypertrophic olivary degeneration, which is actually a rare condition characterized by a unique pattern of transsynaptic degeneration and typically caused by a lesion in the brainstem or the cerebellum, interrupting this triangle of Gillian and Mullaret, which results in hypertrophy of the inferior olivary nucleus. So the hyperintensity that was seen was in the inferior olivary nucleus. So in this particular condition, that is hypertrophic olivary degeneration, the patient presents with oculopalatal tremors, which is a distinctive part of the presentation of hypertrophic olivary degeneration. Although it is also seen in many other brainstem and cerebral conditions, but oculopalatal tremors comprises ocular, palatal and other muscular involuntary movements. The palatal myoclonus, that is rhythmic involuntary movement of the soft palate and the uvula, potentially extending to involve the pharynx and the larynx, is actually pathognomic. So palatal myoclonus is very important clinical feature of hypertrophic olivary degeneration. Along with that, oscillopsia, which may present due to pendular nystagmus caused by the ocular myoclonus, is also seen. And the upper extremity tremors, which were seen in this case, is called Holmes tremor. Along with that, facial, cervical, and diaphragmatic myoclonus can also be present. So the pathophysiology of this particular condition is related to this particular triangle, which is called the triangle of Gillian and Mullaret, which has three important ends, that is the red nucleus in the midbrain, the dentate nucleus in the cerebellum, the inferior olivary nucleus in the medulla. So this is the triangle. So the connection between the red nucleus and the ipsilateral inferior olivary nucleus and the contralateral dentate nucleus forms this triangle of Mullaret and Gillian, and the interruption of either connection between the dentate nucleus and the red nucleus, the dentate nucleus and the red nucleus, which forms the dentatorubral tract in the superior cerebral peduncle, or the connection between the red nucleus and the ipsilateral inferior olivary nucleus, which forms the tegmental tract, can lead to changes in the olive. The olive receives inhibitory signal within the dentatorubro-olivary pathway with transneuronal degeneration causing enlargement rather than atrophy. So there is enlargement of this particular nucleus if there is injury to any of this path.